Welcome back to Therapeutics. What we're going to talk about in this block is some of this content will actually be review of principles we've talked about throughout pharmacology and therapeutics, but we're also going to talk a bit about the kind of issues you'll likely see when you're in practice, either in surgery or in the emergency department or in surgery, things that are related to anesthetics and procedural sedation. We'll also talk a little bit about a few of the things we think about in patients who are in the ICU or critical care that's somewhat unique to those settings. We'll also quickly review the perioperative deep vein thrombosis prophylaxis. We really cover this more thoroughly in the cardiology section where we talk about the antithrombotic therapies. But we'll review this in this block as it relates to patients, either particularly surgical patients, but this could be medicine patients as well, who are candidates for deep vein thrombosis prophylaxis. So let's first look at anesthetics, and we're not really preparing you in this block or in this lecture for really being an anesthetist or an anesthesiologist, but having you just be aware of some of the principles in anesthesia, and particularly as it relates to procedural sedation. In the scope of practice for you, particularly you'll probably see this in your clinical year, if you're working in the emergency department, if you're working in a surgery service, you need to be at least aware of stages of anesthesia, and you may also be involved in procedural sedation with or without an anesthesiologist. Some older thinking in stages of anesthesia, and these still ring pretty true, are this list of stages of anesthesia which were first really developed in the 1920s or so. And in this model of thinking, we see that there are different levels of anesthesia when somebody is slipping into anesthesia, where the stage 1 low level of anesthesia is helping patients to recognize that there is some level of analgesia associated with some numbness, some loss of sensual senses, sensation, feelings. There may be some auditory and visual hallucinations in this phase. And really what we're trying to look at, if you're trying to manage the environment, is to maintain a quiet and tranquil environment. And in some points in this stage, in stage 1, and sometimes in stage 2, patients can get really agitated as they're going under, almost like fighting anesthesia. And in induction, we see this as well. Many patients, for example, may struggle. In a sense, it's a natural reaction for folks who are undergoing anesthesia to fight a sense that's a threat or appears to be a threat. In this stage 2 of excitement 2, we also can worry about vomiting and incontinence, and we're really worried about aspiration. And so many times when we're looking at giving anesthesia for patients, we look at our management of nausea, vomiting, prophylaxis pretty aggressively. And so perioperative and postoperative nausea, vomiting management is important, not only for patient comfort, but also to reduce aspiration risk. The stage 3, at least in the older school of nomenclature, looked at 4 planes of anesthesia, of surgical anesthesia. And really, while someone is undergoing a procedure that either could be painful or disruptive, we really expect that the anesthesiologist is maintaining somebody in one of these levels of anesthesia. And plane 1, the lightest level of anesthesia here, we might see eye movement stop. And as we progress into plane 2, we might have some partial intercostal paralysis. And so we typically will see when we give somebody undergoing this level of anesthesia, important for us to recognize that we need to maintain an airway for folks. What you'll see by level plane 3 and plane 4 is intercostal paralysis up to diaphragmatic paralysis. And so important to maintain an airway and protect against aspiration in these states of surgical anesthesia. And what is sort of problematic is when you get too deep into anesthesia with the level of toxicity leading to respiratory arrest or vasomotor collapse. where you really need to look at resuscitating a patient, and hopefully you don't get to that level. So typically in most anesthesia settings now, at least where we're talking about more significant anesthesia, we'll do BIS monitoring or some other monitoring that would let you know how deep you are in anesthesia a little better than in the, in the days before that kind of level of monitoring was available. Clinicians and anesthesiologists really had to look at some subtle cues about determining which level of anesthesia a patient was in. In your practice, if you're working in surgery, it's going to really be the scope of practice of the anesthesiologist or the nurse anesthetist or that mid-level in an anesthesia practitioner, if that be you or not. Usually it's going to be those people who are going to manage that level of anesthesia. However, in procedural sedation, we're really looking at folks being in a lighter level of sedation, that they're sedated, but you really don't get in these levels of anesthesia when somebody's undergoing a procedure, for example, in the emergency room. So, for example, you've got somebody who's had need some procedural sedation for whatever the procedure is going to be because the procedure is going to be intrusive for the patient, but they're going to be left in the emergency room while that procedure is done. Then you're going to look at what we call conscious sedation. That's a level of sedation that is is less than the level of surgical anesthesia, where you don't see these levels or these planes going on. So let's look at the types of anesthetics. First of all, the volatile anesthetics, these are only going to be used really in the OR by an anesthesiologist or a nurse anesthetist or someone who has that practice. It's not going to be routinely expected that a provider, for example, in the emergency room is going to be using these volatile anesthetics. These gases have been around for decades, and most of the time the hospital will use one of these agents. Probably the most common that I've seen in the last decade or two is either desflurane or sevoflurane as anesthetic gases. But the older agent that's really not used much anymore, halothane, because it caused a lot of hepatic risk, is still by many considered sort of the prototypical agent for anesthesia, volatile gas anesthetics. With all of these agents, in addition to all the other concerns with anesthesia, we would expect to see some cardiovascular effects, including decreased blood pressure. You might see some loss in ejection fraction. Many times patients will get hypothermic. Their respirations will, as we would expect, decline. And there is a risk for malignant hyperthermia. With these agents, important to recognize that you have a skeletal muscle relaxant called dantrolene on board, and recognizing malignant hyperthermia, which presents with muscle rigidity and very elevated temperature. Malignant hyperthermia is usually related to these anesthetics, a medical emergency. It's rare when it happens, but you want to be aware that this could happen for any patient who's in surgery or in the PACU coming out of surgery who's had exposure to these volatile anesthetics. And malignant hyperthermia presents similarly to two other conditions that we talk about in the curriculum as well. One is serotonin syndrome, where there might be muscle rigidity, and one, as we talk about with the typical and to some degree maybe the atypical antipsychotics, neuroleptic malignant syndrome. All of those associated with muscle rigidity and elevated temperature. Other things that might be seen with the volatile anesthetics include emergence delirium. When folks are coming out of surgery in the PACU, they may actually have a delirium kind of phase. We're more likely to see this in older patients than in younger ones. Patients may have shivering, trembling. They might have hallucinations, confusion that may look like delirium. They may also have some level of excitability or nervousness. So all of these are things you should keep your eye out for patients who have recently undergone one of these anesthetic gases. The administration of these gases are done carefully in the OR. What we try to do is to limit the occupational exposure to other people in the OR, working in the OR to these. So most of these systems managed by the anesthesiologist utilize a system for delivering these volatile gases by inhalation during surgery in a way that capture other components of the gas that would escape into the environment. So important that you as a person who's in the OR isn't exposed to these to any great extent while the patient would be. More commonly in your practice, and some of these are going to be agents you may see also in the ER or in the ICU, if a patient's undergoing procedures where we want to use conscious sedation, or sometimes these are used in conjunction with the gases or in combination with the gases by the anesthesia service as well. An older agent listed at the top here is sodium pentothal or thiopental. And this agent historically was used quite frequently, is much less frequently used now in hospital settings, but I think it's important at least you have an appreciation for it because it's on rare occasions still used. And it's a barbiturate. Barbiturates have a pretty low therapeutic index. They cause respiratory depression and some of the other side effects you see here. And so the barbiturates are agents we'd usually try to avoid, but you may still see them used. Much more commonly in patients who get IV anesthetics are using one of the benzodiazepines, and these are pretty commonly used. The three most commonly used in practice that we see routinely are midazolam, maybe lorazepam or diazepam could be used as well. But midazolam or Versed is the shortest acting agent. Typically the duration of action is relatively short, typically a half an hour to up to 2 hours, although it does have an active metabolite that can accumulate if we've given patients lots of midazolam. We'll see midazolam used pretty frequently, for example, maybe in combination with fentanyl for patients who are undergoing, for example, a colonoscopy. You could use diazepam, Valium, it's longer acting, lorazepam, somewhere in between midazolam, short acting, and diazepam, longer acting. Each of these are used sometimes either alone or in combination for either conscious sedation or full anesthesia. Other things that you'll see used, the opioids, are pretty commonly used, and probably fentanyl being the most common. The other three fentanyl derivatives are listed here as well. Fentanyl, though, seems to be the agent used most often in most anesthesia suites because it has a very short onset of action and a relatively short duration. So an anesthesiologist has a little more control over therapy with fentanyl as opposed to using morphine or hydromorphone or any of the other opioids. Like any other opioid, fentanyl associated with respiratory depression, bradycardia, hypotension, confusion, sometimes nausea, vomiting. So you have to be aware of that. But the advantage of fentanyl over the other opioids is almost immediate onset of action and a really relatively short duration, which makes it ideal for procedural sedation. Some of the other agents you'll see listed here, etomidate, we sometimes see etomidate used. The reason I don't see etomidate used as often as some of the other agents, it probably has a little more nausea, vomiting associated with it compared to some of the other IV anesthetics. Propofol, though, is used pretty frequently. Propofol has the advantage of a really quick onset, 10 to 50 seconds, and a short duration, 3 to 10 minutes. It can be associated sometimes with apnea, but any of these agents can, the opioids can as well, particularly with rapid administration. We'll talk about propofol in a minute in a little more detail. Propofol is a very fat-soluble drug that is in a soy-based emulsion as an IV administered product, and so it can become easily contaminated. And so when you work in practice, you'll see this white milky drug, propofol, being administered. You want to make sure that you don't contaminate it when you're giving it, and that we only let it hang for up to 6 hours once we open the bottle. Because this fat emulsion can easily contaminate it. Propofol, if you also remember, you can overshoot propofol. It really needs to be administered by someone who is aware of maintaining an airway for a patient. We do use it for conscious sedation, but it's done carefully with clear guidelines only by providers in hospital settings who are certified in or are trained at least in how to manage conscious sedation. If you remember, this propofol was the agent that was associated with the death of Michael Jackson. certainly in a situation, any provider who would ever consider giving propofol in a setting outside of a controlled situation with continuous ongoing monitoring is really quite inappropriate. Another agent that's used as a central alpha-2 agonist is Precedex. And Precedex is used, it has the advantage of maybe less likely inducing delirium in a patient who's predisposed to delirium. Other than that, Precedex is a more expensive alternative than propofol is. It is used, though, and typically in settings we've seen it used either in critical care for a patient who is on a ventilator and needs sedation, or procedural sedation in a patient, particularly who's older, who has a risk for delirium. That's really it has a lower risk for delirium. And one of the last agents here is ketamine. Ketamine is sometimes used as an IV anesthetic. It historically has been used more as a veterinary anesthetic, but it is used in burn patients as part of a procedural sedation in a burn patient, or in some other patients, sometimes younger patients. The problem with ketamine in some patients is that when they emerge out of ketamine sedation, they often have a dissociative, almost hallucination type reaction. And so we would really want to avoid ketamine in patients who had history of mental illness where they had hallucinations, because this would make things worse. And there are a number of patients still who have that. Would avoid it, for example, in a patient who had post-traumatic stress disorder, because this emergent reaction can be quite disturbing for patients, particularly patients who have a history of post-traumatic stress or something like that. But ketamine has its niche. It is appropriate, usually better tolerated in pediatrics than it is in adults, but that's variable. You'll find clinicians who use ketamine and are familiar with how to use it, so you'll probably see ketamine used in practice. All of these IV anesthetics, the one we had on the last slide and this one here, are either used alone or in combination for conscious sedation. They're also used by the anesthesiologist in the OR in combination with other therapies. So, for example, if a patient might get an anesthetic gas, but the anesthesiologist may also be titrating that anesthetic gas in combination with fentanyl. And it makes sense to use fentanyl or an opioid if you're doing a surgical procedure where pain is a component of that. So you want not only sedation, but you want anesthesia and analgesia as well as anesthesia. So when you want analgesia, of all of the agents we can use, the opioids really make sense to add that to the mix. And so you'll often see fentanyl used when there's a pain component or likely pain component, particularly to the procedure that's being done or the reason why a patient's undergoing IV anesthesia or conscious sedation. Let's now look at some of the things you're likely to see in critical care settings. Typically, when a patient is in critical care, particularly if they're sedated or if they're not verbal, we need to identify whether or not they're undergoing pain and how we assess that. And so there are a number of different scales that are used in critical care. Here's an example of one of a behavioral pain scale that's used in critical care. So the nurses who work in critical care would be familiar with whatever the hospital's routine way to assess that is. But we'll look at things like facial expression, limb movements, and compliance if they're on a ventilator, how compliant they are with a ventilator, and give them a set of score that would help determine whether or not the patient is in pain. And so part of the thing you'll see, for example, if a patient's on a vent or if they're uncomfortable, they can't tell you they're uncomfortable. You know, we talked about pain management. In an acute pain, we can also look at elevated heart rate and blood pressure. And so if a patient is in the ICU and it's acute pain and you see their heart rate go up or their blood pressure go up, sometimes we'll give them an opioid like fentanyl, and we'll see that reverse nicely. And so you could make a judgment that likely that elevated heart rate and or blood pressure might have been associated with pain, and we address that. But in addition to using heart rate and blood pressure for pain assessment, we're also going to look at facial expression, these other things, as an indicator of pain. And important to do that because what you titrate up in the situation of pain would be the fentanyl drip, not the benzodiazepine drip. So you need to kind of have a sense of when you're managing a patient, which agents or mix of agents you're using, and how you address that change in patient status is whether or not it's related to pain. Another pain observation tool that's listed here similarly looks at what we noted in that earlier scale with facial expression, body movements, and compliance with the ventilator, but also looks at some degree of muscle tension as well. So this is a different rating tool that's sometimes used for pain, but they're very similar. We also will use in practice a sedation scale. And so clinically in practice, if you're giving conscious sedation, particularly for a patient in the ICU who is on a ventilator, for example, and we're giving them a sedating agent or an IV drip, maybe a propofol drip, or you're giving them a dazolam drip to sedate them while they're on the ventilator so they're not fighting the vent, the nurse has to be able to titrate that drip based on a certain sedation scale. And the accrediting bodies for hospitals really mandate that we have a very strict set of objective assessments for when a nurse titrates orders that you write. And so typically you're going to write orders that are titrated to one of these scales. Probably the most common scale we see used is the RASS scale, the Richmond Agitation Sedation Scale, where patients will be in a scale from a +4 to a -5. And usually what we're shooting for is a patient to be a -1 or a -2, not more than a -2 with conscious sedation. The reason we want to avoid anything less than a -2, usually, as long as the patient's not fighting a vent, they're not agitated, they're not having delirium. Deeper sedation, you can overshoot it, and then you worry about how long it's going to take for them to come out of sedation. And so you want to be careful about not overshooting it. And also the nurse really needs to be confident of how we're titrating that drip. Another scale that's sometimes used is the SAS scale. I don't see this used as often in a practice as the RAS score we noted earlier, but this is another sort of similar scale that could be used. All right, let's talk about some of the agents in a little more depth. Let's talk first about propofol. Precedex is also used in place of propofol, particularly at this place I've seen it are situations where a patient is predisposed to delirium, and that's really the place where this fits, where you want to avoid a benzo or you want to avoid propofol when a patient has a risk for delirium. But you may or may not see this agent used depending on where you practice, but it's likely it's going to be somewhat limited in its use compared to propofol, for example. So as we're looking at the IV anesthetics, the advantages and disadvantages, you want to sort of think about these. The advantages of IV anesthetics are that you can induce unconsciousness and even conscious sedation pretty quickly. People will often not remember what's going on. They'll often have amnesia. That's particularly true for the benzos and for propofol. And they often will have recovery pretty quickly. They're pretty easy to administer because they're IV. They don't usually cause a lot of irritation like the gases do to mucous membranes. There are not flammable risks that the anesthetic gases have, and there's less chance for occupational exposure. But the disadvantages of the IV anesthetics are they might be irritating to the vein or lead to a risk for gangrene or thrombosis if there's an extravasation of that IV infusion. They often will be associated with hypotension, sometimes apnea on administration if it's quickly administered, and they often don't have, with the exception of the opioids, don't have a lot of analgesic effects. So those are the IV anesthetics. Next are the local anesthetics, and these are either used topically or local injection sites. So these are going to be injected like lidocaine, for example, is probably the most common example of an agent used, but any of the benzocaine, lidocaine, procaine agents that are topically applied or injected locally or used as a nerve block And the agents we'll see used in the critical care setting, in the hospital setting, most often by anesthesiologists include bupivacaine, lidocaine, sometimes procaine, prilocaine, tetracaine. Each of these agents are used depending on the site of in the route of administration. In subarachnoid blocks, also anesthesiologists typically talk about nerve blocks or spinal blocks. These are typically going to be done by the anesthesiologist. Epidurals, again, going to be initially set up by the anesthesia service, usually not by a primary care provider, and use one of these agents. They're used for when we want to localize our analgesia without having maybe central nervous system effects, or we want to avoid or spare use of opioids. These, for example, would commonly be recommended, for example, an epidural in delivery, where you don't want respiratory depression in a newborn or in the fetus or in the newborn during delivery. And so delivering anesthesia to a patient without affecting central nervous system function all that much, or particularly avoiding respiratory depression in a newborn. The opioids that you're going to see used in critical care, we will probably most often in the OR see the use of fentanyl, but in the ICU you could use morphine, fentanyl, or or hydromorphone, and their kinetics are listed here. Fentanyl has the advantage of a quicker onset but a shorter duration of effect typically than the other two agents will. And doesn't have as much fentanyl doesn't have as much hypotension associated with it, and so that's really the agent you'll see the anesthesiologist use most often. You do want to keep in mind, though, that the potency of these agents is different. So the milligram or microgram amounts we're using for these agents vary. You need to be very, very careful in picking the correct dose for each of these agents. The benzos that are used typically and most often in critical care and in the OR, we're going to use the shortest acting agent, which is midazolam, lorazepam moderately longer acting, and diazepam is longer acting as well. At least the hangover effect, the half-life is considerably longer with active metabolites that hang around for a long time. So each of these are considerations in your choice of which of the benzos you'll pick. We already talked about, or in a separate area, talk about acute delirium, but you want to keep in mind that delirium happens, and typically to avoid delirium in patients who are at risk for delirium, we often want to avoid the benzos, even though your first initial thinking is, hey, I want to calm somebody down. A benzo makes sense if they're in delirium. It doesn't, partly because the benzos cause memory impairment. The memory impairment and confusion contribute to the patient's sense of lack of control, which contribute to more delirium and confusion. And so in critical care and other settings, we'll sometimes use a typical or an atypical antipsychotic. And the two I think we see used the most often, I see used the most often at least, is either Haldol given IV typically, or if we're giving oral and the patient tolerates oral, quetiapine or Seroquel. Keep in mind that all of these agents predispose to prolonging QT intervals, and Haldol also associated with prolonging the extrapyramidal symptoms of muscle rigidity, Parkinsonian tremors. Although interestingly, and I cannot explain this, when we give Haldol IV in the ICU, we usually don't see those extrapyramidal side effects as often. And I'm at a loss to understand why that is, but that just happens to be the case. All right, and we're going to switch gears now, talk a bit about the neuromuscular blockers. The neuromuscular blockers are used occasionally in critical care. They're used more often in surgery. They are sometimes and really quite rarely used in the critical care setting for patients who are on a ventilator and sedation isn't enough for them to fight the vent. Basically what these drugs is they blunt neuromuscular function. And so neuromuscular blockers absolutely make sense in surgery, particularly in neurosurgery in a situation where we're worried about any muscle twitching going on during surgery. So neuromuscular blockers would be commonly used in a patient who is is well sedated and has an airway in place. We will sometimes also use it to achieve paralysis before we intubate someone. If we do that, we typically would very quickly give them a rapid-acting sedating drug like midazolam or propofol, use succinylcholine that's short-acting, and then intubate a patient, but get the airway in place right away. No delay for airway. We also will see these agents used for preventing any other kind of muscle spasm, either during a procedure or affecting that, but it will affect the intercostal function as well, so an airway is essential. We need to keep in mind with neuromuscular blockers that they don't have any analgesic effect. They don't blunt seizures. The patient will look very relaxed because they don't have muscle tone. But they'd have no central nervous system action, so a patient, if they're not adequately sedated, are absolutely panicked and can't breathe and can't move their limbs. So you absolutely, before you use a neuromuscular blocker, always sedate the patient and have the airway in place. The other thing with neuromuscular blockers is, particularly those that are longer acting, or if you're giving continuous dosing of these agents, particularly like in a longer surgical procedure or in the ICU for a patient on a ventilator, which we don't do all that much anymore, you want to check how far along the patient is, how deep they are into neuromuscular blockade, and we'll use a peripheral nerve stimulator to test for train of fours. And I encourage you to look on the website, website that we post content on, to see if we have a YouTube video on using the train of fours. It's a fairly short video, but you really do need to recognize that. And what we're doing is we put a peripheral nerve stimulator on a patient who has a neuromuscular blocker drip on board, and we stimulate their nerve, their ulnar nerve typically, to hopefully see 1 or 2 twitches instead of 4 twitches, which means that you have adequately suppressed their neuromuscular function so they won't do twitching on their own, but you haven't so deepened their neuromuscular blockade that will be hours or days until they come out of that neuromuscular blockade when you turn the drip off. So all of these are important considerations to make as a practitioner. Please look at that relatively short video as you do that. So let's look at some of the neuromuscular blockers. The older one that people don't use much anymore, but it's considered the prototypical neuromuscular blocker, is pancuronium. It's an older, non-depolarizing neuromuscular blocker or paralytic agent that's been around for a couple of generations now. The problems associated with it is that it has more risk for hypersensitivity and also affects heart rate and other functions as well. It's fairly long-acting, and so it's an agent that we don't see used much anymore, but you'll still hear people talk about pancuronium or pan. Adverse effects, as we alluded to, some cardiac effects. There's some potential drug interactions, and dosing is listed here, but again, an agent you won't see used very much. Other issues you'll see is its onset, duration, and safety considerations, again, an older agent. If you work in critical care or you work as a paramedic, you may be familiar with succinylcholine. Succinylcholine is a depolarizing neuromuscular blocking paralytic agent. The advantage of succinylcholine is it's short-acting, and so we will use this agent to facilitate intubation, usually for very short-acting agent that's only going to last for 5-10 minutes or so. And usually we only want it when we have a very short procedure where we don't want somebody to have muscle spasms. And typically this is intubation is classically the role for it. The adverse effects for any of these agents is apnea and stopping breathing, so you have to have the airway in place. You're only going to use this as you're intubating a patient, but first you're going to sedate the patient well before you give them succinylcholine. And the dosages here, it's typically has an onset in a minute. Its peak effect is in a couple of minutes, and for most patients, unless there's 1 in 1,500 patients or so who have a genetic predisposition to have succinylcholine last a long time, usually expect after 5 minutes the effects had pretty much worn off. One of the other agents that you see more often used, there's a few of them, is vecuronium, rocuronium. There's a few others that are used depending on what the preference is with the anesthesia service you see. The remaining agents are really chosen based on their onset and duration of action primarily. Vecuronium is a non-depolarizing neuromuscular blocker, is used to facilitate intubation, but also used in surgery as well. It has problems, as all of these agents do, with narrow angle glaucoma, myasthenia gravis, but for the most part, those aren't usual concerns for you in most patients. Adverse effects, sometimes you'll see cardiac effects with these, so you have to keep that in mind. But the dosage and pediatric and adult doses, both IV push and maintenance doses listed here. And the duration of an onset and duration of vecuronium, what make it kind of a useful agent for many clinicians is that its onset is within 30 seconds, has its peak effect in a couple of minutes, and by 25 or 30 minutes, the single dose starts to wear off. So if your procedure is maybe 15 or 20 minutes, this might be all you need is a single dose of vecuronium, and it pretty much does the trick. There are other neuromuscular blockers that vary based in their onset duration of action, and you'll see any one of these agents used. You could see atracurium, cisatracurium, mivacurium, rocuronium, and the choice of these agents really, we tweak them based on their onset and duration of action. So here's a table that sort of compares some of the more common agents with their pharmacokinetic and pharmacodynamic profiles and the doses that are used. There are also some interactions with the neuromuscular blockers. You want to be aware of other agents that can potentiate or antagonize blocks. Potentiating a block, the most important of all of these groups I've heard people indicate are the aminoglycoside antibiotics, gentamicin and tobramycin. Most of the other interactions are, since you're titrating to effect anyway with any of these agents, usually aren't all that critical. You do, however, want to watch for cardiac effects and keep an eye on all the electrolytes, mag, calcium, potassium in particular. Keep an eye on the QT interval for patients and look for any cardiac changes while they're undergoing neuromuscular blockade. Let's now talk about medical and surgical prophylaxis. And the intent of prophylaxis, particularly prior to surgery, or for other conditions sometimes, is to treat before bacterial contamination occurs. So our intent is to have, in prophylaxis, to have high levels of the drug in the blood and in the tissue before we actually, take out the scalpel and actually sort of cause an invasive to tissue and blood bacterial exposure. So the ways we're going to do that and to reduce that risk for infection for these patients, surgical patients, is first to make sure that we address all of the skin flora. Many patients go into surgery, for example, the night before. They will have a bacterial wash that they'll take in the shower right before they're coming into the hospital. And then they'll have their localized area perhaps shaved and scrubbed appropriately with an appropriate antiseptic for a long enough period of time. And so there's all of those treatments we'll do. And then typically a half an hour to an hour before surgery starts, the anesthesiologist will administer the first dose of an appropriate antibacterial agent to get high levels of antibiotic in the tissue so that should during the surgical procedure or intervention there be a transient amount of that pathogen in the blood or in tissue, you've got adequate tissue and blood levels of that antibiotic to address it to help the patient to sort of wipe it out. We also can use therapy early after the patient presents. That's not as ideal as prophylactically, but that might be an issue, for example, when somebody's already had an exposure and you realize that you can do something about it. So a post-gunshot wound or post-something else. We don't have a rip-roaring infection yet, but their risk for bacterial contamination is high, and so we're prophylactically treating it, but we're doing it early, not before the exposure happens. And then we always worry about risks for postoperative wound infections and bacterial contamination. We are depending on what the exogenous or endogenous issue is. Is it patient flora because we've had trauma to their GI tract, maybe a below the diaphragm gunshot wound into the abdomen, for example, or whether there's some flawed technique happening. We always think about the host resistance, very young, very old, nutritional status, obesity, diabetes, particularly as it relates to wound healing and glycemic control, if they're immunocompromised, if their oxygenation is poor, if they have infection somewhere else, or they have a foreign body. All of those are sort of, hey, these folks are much higher risk for postoperative wound infections. The Center for Disease Control classifies wounds by 4 categories: clean, contaminated, contaminated, and dirty, infected. Clean surgeries, clean wounds are considered those that are where you're, for example, you're suturing or you're going into a scalpeling or cutting into an area that is where there's generally a low risk for infection. Where we consider more clean contaminated is if your operative wound site involves areas that may be colonized. And so for the clean wounds, we're covering basically staph and strep coverage as part of our prophylaxis for a clean wound, and really only need to do that immediately prior to surgery and throughout the surgical window of time to make sure that the antibiotics covering staph and strep are reasonably high levels in tissue and blood throughout that operative window. Clean contaminated are those that your surgical wound site might be around an area or near an area, adjacent to an area that may be colonized in one way, shape, or form: respiratory tract, genital tract, urinary tract, alimentary tract, for which there is a higher risk for a broader number of pathogens that could be involved. And so your prophylactic antibiotics for those clean contaminated surgeries are going to be influenced by what likely adjacent pathogens could be introduced beyond skin flora. Contaminated are those where there is some break in surgical technique, but it's a fresh, immediate wound, and so or immediate gross spillage of gastrointestinal contents, and so our spectrum is going to be more aggressive. And then finally, the dirty infected are those older traumatic wounds that have devitalized tissue, involve an existing wound that's already festering or becoming problematic. Those are more difficult to manage. The person already has or has developed some degree of infection already with all of the responses to that, and those are probably the most aggressive to manage, and those often require also localized drainage or some sort of a debriding of a wound or something in those cases as well. The principles of effective prophylaxis are the timing, and most often when we talk about prophylaxis here, we're going to talk about surgical prophylaxis, but these also refer to other prophylaxis. We've already briefly talked about prophylaxis regarding endocarditis, for example, where we give it within the hour before, amoxicillin orally within the hour before their dental procedure. The timing of the antibiotic is such that when we give it, particularly pre-surgically and around surgery, is we want to give it so that the levels in the tissue are high at the point of incision and throughout the operative period. So if we're giving IV antibiotics, we could give that within, depending on the agent, within just a few minutes up to an hour before incision. And then during the operative window, if it's a surgery that goes beyond 3, 4, 6 hours, we need to give an intraoperative dose as well, because the levels during that 4, 6 hour procedure, the levels in the tissue and the blood have gone down to such a level that we need to redose it. Most of the time, and most of the recommendations from the CDC is use the narrowest reasonable spectrum agent you can use for the procedure you're doing based on the patient factors and environmental factors in that hospital, for example, for MRSA rates, for example, and only for pre and perioperative, around the operative window. There are some circumstances where you can use post-op antibiotics within the 24-hour window post-surgically. The CDC and other settings usually recommend avoiding that because they probably don't really decrease the rate of post-surgical wound infections beyond the operative window, but there are some exceptions for certain cardiac procedures, and in practice, we still see a lingering practice for post-operative dosing for the 24-hour window after other procedures like perhaps orthopedic surgery procedures. But there's varying debate about whether that makes sense to do that or not, keeping in mind that unnecessary antibiotics contribute to the resistance patterns that can develop with such widespread use. And the spectrum of activity that's chosen for prophylaxis depends on whether it was clean contaminated, those kind of issues we talked about a bit earlier. So we want the spectrum to cover skin flora unless it's a more than a clean surgical procedure, and then we want to sort of target our interventions appropriately. So let's look at an example of what One Health System has listed and published online for their surgical prophylaxis recommendations from Stanford Healthcare in Palo Alto, California. They have a number of recommendations as part of their recommendations within their healthcare setting for preferred agents based on the type of surgery, and some of those are listed here. For example, most of the surgical interventions they're concerned about, they're really only worried about skin flora, particularly staph and strep, to which unless MRSA were a problem or unless there was a beta-lactam allergy, they would recommend just cefazolin, a first-generation cephalosporin. In circumstances where there's added risk, in addition to skin flora, they may add a second agent. For example, for a prosthetic valve in cardiac surgery, they recommend the addition of vancomycin because MRSA risk is much higher in those circumstances. For colorectal surgeries, they recommend anaerobe coverage, particularly for bacteroides, with metronidazole. Other procedures they recommend are listed here. Again, you'll see that for typical clean surgeries, we're looking at just plain old cefazolin. In head and neck surgeries where there is more contamination risk, then they layer on, or we'll look at addition of anaerobe coverage, for example, if there's concern for contamination, particularly, for example, oral anaerobes. Again, the same principles here. Most surgical procedures are looking just at cefazolin as a reasonable first-line therapy. Now, in urologic surgeries, they're a bit different. Their risks for different concerns are there, depending on what the nature of the procedure is. And so you may see an issue that needs more anaerobe coverage or different pathogen coverage. And some of this is also directed by the hospital's antibiogram and their own individual surgical history data within their organization. The nature of dosing of drugs is listed in this table. Stanford pretty much looks at standard, pretty aggressive doses of cefazolin of 2 grams, and for larger patients even 3 grams, with a redosing if the surgical procedure is prolonged beyond 4 hours for cefazolin. Clinda's a little longer acting. You can get by with a not needing a redose unless the surgical procedure is 6 hours. And vancomycin for most patients, depending on how it's dosed and what the patient's renal function is, they don't recommend a redosing until up to 12 hours. Other agents here listed their recommended dosing, and you can see, for example, for Amstelbactam, if that were to be considered, they recommend a redosing within 2 hours because pretty short-acting agent, pretty short half-life. And you can go down this list and see further recommendations. Again, dosing listed here. Usually minoglycosides are a single dose, particularly when you pick a high 5 milligram per kilogram single dose where there's a post-antibiotic effect. So that's a non-issue. Same is true for fluoroquinolones. So it depends really on the agent that you're sort of looking at. Finally, wrap up of some standard recommendations for procedures. Typically, you look at whether or not there is a post-operative dosing recommendation. And usually they don't recommend post-operative dose of antimicrobials, but if they're required, usually in highly risky surgeries where there are concerns for infection rates or might be higher, then we look at maybe post-operative doses after the close of surgery, and really having all of these doses administered within 23 to 24 hours after the close of surgery. And then finally, there are recommended post-operative doses again for last agents. So here's an example. Sanford Healthcare has their recommendations. When you practice in a particular setting, those recommendations for that setting usually will pretty much mimic these here. You'll see them pretty similar. You may see some subtle differences based on the antibiogram of that setting and or different issues that relate to practice that might be around that particular setting. Okay. Other things that you need to think about both in surgery, post-op, and in other critical care settings as well is the management of antiemetics. We talked about this already in two different areas, in the curriculum, in the GI block, and to some degree in the hematology-oncology block. But keep in mind this is also an issue, so it's a bit of review in surgery patients particularly. And so we look at the stimuli for nausea, vomiting. We have visceral stimulation via the serotonergic and dopamine receptors. We see chemoreceptor trigger zone triggered issues. We see vestibular labyrinth issues, and we see cerebral cortex. And typically when you look at perioperative and postoperative nausea, vomiting, often we're going to focus on serotonin and dopamine. We may use some of the other agents as well, or some of the other considerations, but usually where those are going to be our primary focus in peri-surgical patients. As we look at conditions associated with nausea, vomiting, certainly surgery is a big one, but layer on top of it these other conditions where nausea, vomiting would be problematic. So surgery in conjunction with a patient who has an infectious or GI condition or has CNS issues going on, or endocrine issues, all of these are sort of predispositions to make maybe higher risk for nausea, vomiting. And then the concerns for nausea, vomiting, the biggest one you probably have in surgery is aspiration risk, but you're also going to be worried about dehydration, electrolyte disturbance, and with retching, a Mallory-Weiss tear. So again, as we noted in the GI block, these are all concerns again here in these surgical patients. This is a review set of slides here for the antiemetics. You should have seen these already. The phenothiazines, promethazine, and prochlorperazine are sometimes used in surgical patients. I think in our practice that I've seen in surgical patients, less commonly used. The serotonergic agents, though, serotonergic antagonists like ondansetron is pretty commonly used for perioperative, postoperative surgery patients in combination with other agents. The antihistamines, not all that commonly used in surgical patients from my observation. We do, however, see the butyrophenones used pretty commonly by anesthesiologists, either Haldol, haloperidol, or droperidol or napsine. These will, however, prolong QT interval, so you need to be aware of that. And the NK1 antagonists, less commonly do I see these agents used in perioperative patients. Finally, as antiemetics, you may see one of these other agents used as an antiemetic, not all that commonly used that I see in perioperative patients. Sometimes scopolamine I'll see used. Dronabinol for the isolated patient for whom THC does make sense as an antiemetic, you will see used. The other agents, not all that commonly used. Okay, let's think about other critical care situations here, and one is something called stress stress-related mucosal disease associated with critically ill patients. And these are patients who have stress-related injury to the GI tract, and these can be superficial but diffuse upper GI ulceration associated with significant stress. They're usually seen the more severe stress ulcers are seen in patients who are medically very compromised. Usually we see these kind of concerns being the greatest for patients who are on a ventilator. 2 decades ago, we thought this was a much more common problem in the hospital, and so we used to use acid-suppressing agents routinely in almost every patient in the hospital because we thought this was a bigger deal. We don't really do that as much anymore, partly because we know the risks associated with acid suppression, particularly the proton pump inhibitors. In this day and age, we do have a worry or concern, potential concern, about the risk for C. diff, for example, and some of the other risks we talk about with proton pump inhibitors. We only really recommend them now for patients who are higher risk in ICU settings and not routinely for other patients. So let's look at some of the risk factors for stress-related mucosal disease in the critically ill patient. Clearly, patients on a ventilator or some of these other issues. They have coagulopathies, they have GI bleeding already or risk for GI bleeding. They're in the ICU for a long period of time. They have overwhelming sepsis. They're on high-dose corticosteroids. You get sort of the picture here. These are the only patients for whom we're going to use stress ulcer prophylaxis therapy. And you could use antacids. You could use sucralfate. Typically, the problem with those two groups of agents, they require multiple doses. They don't really work all that well. The agent of choice, I see clinicians often steering to are the H2 blockers. And the reason for that is they do pretty well for most patients. As long as you don't have an existing major GI bleed, they'll usually do what you need, and they are less likely to cause C. diff. And C. diff is really a problem we try to avoid in critical care, in all patients, but in critical care, those are just one more problem you don't want to add on to. If you have a patient, however, who has a serious high-risk bleed, risk for bleed, high risk, then a proton pump inhibitor is probably going to be more effective for a subset of patients who are highly risky or have an existing upper GI bleed. But short of that, higher dose histamine 2 blockers probably make more sense and probably have a lower risk for C. diff. The agents and the doses are listed here. These are sort of a review of what you'll see for dosing we talked about earlier in the GI block. Okay, the last area is also somewhat a review. So the regimens for prophylaxis, and keep in mind these are lower doses than we use for therapeutic. Differentiate here, we're talking prophylaxis for preventing a DVT in a high-risk patient, but a patient who does not have an existing thromboembolic event. If you're looking at therapeutic for an existing patient with a DVT or a PE, we need higher doses than what we list here. What sort of falls in the middle of dosing is a patient with AFib. And we've already talked about that, but usually patients with AFib, we give them the full dose of the anticoagulant. Here we're talking lower doses really for prophylaxis for deep vein thrombosis or pulmonary embolism. Sub-Q heparin is cheap, commonly used. The problem with heparin and sub-Q heparin is it has a higher risk for thrombocytopenia than perhaps some of the other agents do. Lovenox may be a slightly lower risk. And Arixtra of fondoxaparin is usually limited to patients who have a higher risk for hits. So prevention, as you'll see here, we'll typically look at the agents we'll give subcutaneously, or listed here, either unfractionated heparin, low molecular weight heparin, or Arixtra, sometimes used as a third choice here. Sometimes, though, keep in mind, and not listed here, we will see some of the novel oral anticoagulants, particularly either apixaban or rivaroxaban are the two I see used in some orthopedic surgery patients, and we talked more about those. The last thing I'm listing here are some of the highlights within the very dense set of guidelines by the American College of Chest Physicians. They're updated every 3 or 4 years, and you can see this data sort of published every so often. This is the latest set that were published in February of 2016. We already talked about many of these issues already earlier in the curriculum. I'll refer to you to look at these again, but keep in mind that I'm going to just highlight as it relates to key concepts related to DVT prophylaxis in primarily surgical patients. So, and what you'll see in these updates are changes, whether it's shaded or not, were the changes in the 2016 updates from earlier updates. So, in patients with acute DVT, they recommend not using compression stockings at all, and instead using pharmacologic therapy. Preventing a DVT or VTE in a non-orthopedic surgery patient, the recommendations are listed here, but typically we'll look at weighing the bleeding risk for patient versus the thromboembolic risk for patient and deciding which therapy makes sense for each of those patients. And for other patients here, for sort of more guidelines as far as weighing the risk and the benefit of bleeding complications versus the risk of pharmacologic versus mechanical. But usually you can't go wrong if somebody doesn't have a VTE already and they're low otherwise risk patients to use mechanical ventilation boots on patients who particularly aren't ambulating. But for higher risk patients, looking at pharmacologic therapy. In cardiac surgery patients, you're going to weigh some of the same considerations we saw with non, but usually we're going to look at using pharmacologic VTE with either low molecular weight heparins or unfractionated heparin. For thoracic surgery patients, their guidelines are a little more tweaked than in other patients that are listed here. For craniotomy patients, again, they're sort of listed here, but basically we'll look at mechanical prophylaxis depending on what the bleeding risk. The issues are the bleeding risk in craniotomy patients are concerning, and so you really want to look in those patients at maximizing mechanical. Keep in mind with each of these little tweaks here, what we're looking at is weighing the risk and the benefit of a bleed, particularly related to the surgical procedure, and their risk for thromboembolic event. Spinal surgery patients, we typically look at looking at mechanical over pharmacologic because the spinal surgery itself is a risk for a bleed. So you want to be very careful about those circumstances we use pharmacologic therapy. Again, more issues, particularly with traumatic brain injury, the risk versus the benefit of bleeding plays out here. In orthopedic surgery patients, particularly total hip and total knee, almost always we look at fairly aggressive use of anticoagulation for DVT prophylaxis and of longer duration. And in these patients, it could be low molecular weight heparin, it could be unfractionated heparin, or what's coming popular is one of the novel agents, dabigatran, rivaroxaban, apixaban, you'll see, depending on the practice area you're in, or warfarin therapy. In addition, we'll sort of look, particularly for total knee, there'll be more aggressive dosing than in total hip patients. Finally, more specific guidelines as it relates to orthopedic surgery patients in this slide as well. And then some other prevention issues for orthopedic surgery patients, particularly in folks who have other non-knee or hip patients where they recommend other variables of lower risk or variable risk. Perioperative as well, what you need to think about if you're managing antithrombotics in a patient who, for example, has already been anticoagulated, either with a vitamin K antagonist like warfarin, which is becoming less common, or one of the DOACs or Lovenox. you need to do what's called bridge therapy. I think we talked about that a bit earlier, but typically what you need is you need to stop the other anticoagulants and use a shorting-acting anticoagulant for 4 or 5 days before they go to surgery. Stop the agent during the surgical procedure as is appropriate so that the window of time where they're not anticoagulated is as short as possible, and then restart the anticoagulation immediately after surgery when it's safe to do so and they won't bleed into the surgical site. Typically, as a clinician, most clinicians will ask the surgeon, when is it going to be safe for us to restart anticoagulation based on not only the type of procedure that was done, but what happened in the OR? Did you see something in the OR that made you think that this patient is going to bleed into that suture site or bleed into the wound, and as such we need to delay the restarting of the anticoagulant? So all of these are issues for folks who are already anticoagulated for another reason, a compelling indication. They've had a DVT, they've had a PE, they have AFib and high risk for stroke. All of those issues, you need to manage the anticoagulation around the surgical procedure where the window of time is the shortest safe window of time around surgery to lower the risk for a future clot, but very cognizant that when you restart the anticoagulant, they could bleed into the surgical site. So more issues for how we, in minor versus major procedures, the kind of recommendations, the guidelines are listed here. Again, minor dental procedures, how you manage it perioperatively. Keep in mind that for some minor procedures, you may not need to interrupt anticoagulation at all. But depending on the nature of the risk for bleeding and the compelling indication for the anticoagulation in the first place, guides the decision about whether or not we continue anticoagulants or antiplatelet therapy perioperatively. Again, more issues for coronary bypass or patients who have a stent. Typically, these patients are also at risk for thromboembolic events related to their coronary events as well. Some of the last things we'll see here are perioperative management of antithrombotics when we talk about the use of unfractionated heparin or using bridge therapy with low molecular weight heparins, and some guidelines here. Okay, so in anesthesia, we're expecting certainly you'd know two agents that I expect you to know dosing of is enoxaparin. And keep in mind, enoxaparin, the Lovenox dosing is going to be different for DVT prophylaxis than it's going to be for therapeutic. Therapeutic, we're using usually 1 milligram per kilogram every 12 hours, or maybe 1.5 milligrams, 1.5 milligram per kilogram every 24. That's therapeutic. For prophylaxis, we're talking at something like 30 to 40 milligrams once or twice a day, depending on the indication. Higher risk for thromboembolic events would be knee replacement, where we're going to give more Lovenox for prophylaxis. Sometimes you'll see 30 twice a day or even a little more than that, depending on the size of the patient, whereas most other DVT prophylaxis is 30 or 40 once a day with Lovenox.